So thank you everybody for being with us this afternoon. Welcome to the Cicely Saunders Institute. It's our first in-person Cicely Saunders International Annual Lecture since pre-COVID. So it's a really wonderful occasion to have so many of you invited guests back in the room with us. And also welcome to the large number of people who are joining us and watching online through our Cicely Saunders International channel. And may I draw your attention to the screen for those of you watching online and those of you that have your phones in your hand. If you could join the conversation online with the hashtag and follow us also with the faculty and the Institute. So my first job this afternoon is to introduce Professor Graham Lord, the new Chief Executive of King's Health Partners. Thank you, Graham.
So thank you very much, Richard. Welcome to everyone in the room, and I think over 1,000 people online, as you said, on the Cicely Saunders International channel on YouTube. So very exciting. I feel like a television star, so I even put on a tie, Richard, so to follow your lead. So King's Health Partners, which is essentially a university NHS partnership in South London, is here to deliver. Our mission statement is pioneering better health for all. I guess what that really means in today's context is to translate cutting-edge research and existing best practice into excellent patient care, but also to then research so that we move clinical practice forward through research and innovation, so that actually in 5 years' time we're better at delivering palliative care than we are today. So it's a real pleasure to introduce the annual lecture being delivered from the Cicely Saunders Institute at King's College London. Within King's Health Partners, the palliative care clinical academic group housed at this institute makes a major contribution to our goal of joining mind and body for better patient outcomes, not just in South London, but nationally and internationally. Some recent achievements include the new Dementia Empower Network, led by the Cicely Saunders Institute Director, Professor Catherine Evans. I don't know where she is. She's there, right on the front row, as you should be, but importantly funded by the National Institutes for Health Research, ESRC, and the Alzheimer's Society, so a true multi-funder initiative. In terms of research, I was just talking to a colleague from the Lancet Respiratory Medicine. The EU-funded Better B trial, which was published in the Lancet Respiratory Medicine in the last few weeks, which reported a drug trial for management of breathlessness led by Irene Higginson, who's also sat there in the front row. So congratulations, Irene, on a fabulous paper and piece of research. Also in research terms, the largest UK palliative care study ever of black and minority ethnicity communities, now recruited, led by Sabrina Bajwa and funded by NIHR, who spoke very movingly at the King's Health Partners annual conference last week. Congratulations. In terms of clinical academic integration, Dr. Stephen Ashford was awarded an NIHR Senior Clinical and Practitioner Award. We also like to influence policy, both locally and nationally, and Professor Catherine Sleeman is leading NIHR's first funded policy research unit in palliative care. Quite an extraordinary outcome by which we hope to make sure that the right conversations are being had in central government about palliative care. And in terms of the clinical space, we've initiated dedicated end-of-life care rooms on the wards at King's College Hospital, where we are at the moment. And you can see many more detail of recent achievement in this triennial report, and I'm sure will give you good bedtime reading, but it really is fantastic. So I do commend you to look at this. It's an extraordinary collection of impact that the CSI has had over the last 3 years. So it's now my pleasure to introduce David Hui. And David is the Director of Supportive and Palliative Care Research at the University of Texas MD Anderson Cancer Center. He's duly certified as a practicing medical oncologist and a palliative care specialist. He's a clinician scientist with a research focus in symptom management and integration of oncology and palliative care and prognostication. And he's also a fellow of the American Academy of Hospice and Palliative Medicine. So it's a delight to have you here today, David. And today you will talk on, as you can read on the slide, the timely integration of oncology and palliative care, a rapidly evolving paradigm. So David, over to you. Thank you.
Good afternoon. Thank you, Graham, for the introduction. And it's very deep honor to be here today, to be at the Cicely Saunders Institute, and to be in person with you to talk about a topic close to my heart, and to get a chance earlier to meet the many professors I cite, as well as the young minds who are going to be the leaders of palliative care coming up. And so I'd like to thank the organizing committee, Dr. Harding, Dr. Higginson, and the group for this unique and special chance to be here with the Namesake Institute with Dr. Cicely Saunders. So because the title is timely, I got to finish this in about 35 minutes. So we shall get going on the ride together. Here are my disclosures. And we will talk about the evidence of how far we have come along, where we are now in regard to integration, and we'll talk about the future a little bit, what are some tips as we go forward, and we'll talk about that a little bit more before we summarize. But first, let's start to talk about someone I admire. Dame Cicely Saunders, here's a quote: "Palliative care above all is concerned with journeys of discovery. For patients, a discovery for what is lasting and important for them as they unravel some of the knots and deceit and regret, and for those who love them, the discovery of their own strengths in new roles to help them to live on and finally to find something new to live for, and for all the staff, the continuous search for medical, nursing, and counseling excellence." And this is what we're searching for, this excellence. So in this presentation, we'll see what we have discovered over the past few years. Well, let's start talking about our patients. Our patients with cancer is the focus of this presentation here. And whether patients have incurable disease or curable cancer, we discover that they have a lot of supportive care needs. The needs include cancer-related symptoms that change over the disease trajectory, treatment-related side effects, comorbidities that patients have with them, psychological distress starting from the time of diagnosis, information needs, caregiver support needs, as well as for patients with incurable disease, end-of-life care issues. Now, as you all know, palliative care started out focusing on patients at the very end of life because of the vision and recognition that these patients, have a tremendous amount of suffering. But what we discover over time is that, patients even much earlier in the disease trajectory also have similar concerns. And so I think over time we have evolved a little bit to have this, what we call supportive and palliative care, providing this care for patients earlier in the course of disease. And in fact, when I talk to patients, and they look at this slide and they ask me, so why is supportive care not providing care to patients with even curable disease? And I say, you're right, I got to add this part too. Maybe we can evolve into supporting these individuals if the bandwidth allows. So of course, this is fundamental to the heart of palliative care, is this understanding that physical, emotional, social, spiritual, and informational needs are all strongly integrated with each other, and that in order to alleviate the suffering or treat any symptom, let's say dyspnea, we cannot just, treat the physical elements, but have to address the emotional, social, spiritual, and informational aspect. And to do that effectively, to the vision of them, Cicely Saunders, is to have this interprofessional team where the patient is in the center, families oscillating, and then here we have the team all working closely together in a situational leadership fashion to support patients. I know I'm speaking to the converted, so we will not focus too much on this, but I think this principle is at the heart of what we do every day. And then we also have developed multiple models of supportive care delivery. Going beyond hospice care in the community, we now have well-established home care, palliative care programs. We have in the hospital, inpatient palliative care units in some settings. We have the mobile or consultation team inpatient, and then as well, outpatient clinic and even telehealth. That's been rapidly evolving since the pandemic in particular. And if you look at this diagram here, you can see along the disease trajectory, the community-based as well as the inpatient-based program tend to focus on patients who are sicker by definition. So really, if we want to deliver palliative care earlier in the disease trajectory, we need to have more of the outpatient and potentially telehealth interventions. And so where's the evidence? Well, this is 14 years ago now. TAMO had this landmark study randomizing patients to integrated palliative care versus routine oncologic care. And we see that the quality of life improved along with patients' mood. They have less aggressive end-of-life care. And in fact, the survival improved as well in this as a post-hoc secondary analysis. So this really got everyone very excited. And since that time, many randomized controlled trials been conducted in different countries. And as you can see, there's this growing number of systematic reviews, some conducted by the group here, essentially confirming that palliative care, yes, we can improve this very complex, multidimensional outcome of what we call quality of life, but also symptom burden, and some studies also support the survival benefit. I like to highlight even some newer studies that's been done, and this is one that was conducted in China. And they have also early stage of palliative care development, but the oncologist working with the nurse specialist, dietitian, and psychologist. And in this study, the primary outcome was survival. And they did find a significant improvement in these patients by about 4 months, which is very gratifying to see. And along with that, improvement in quality of life and the other secondary outcomes. Here's another study. In Mexico, the National Cancer Institute there, they see that patients who are randomized to this palliative care group compared to routine oncologic care also has a survival benefit. This time, even bigger difference, 18.1 months versus 10.5 months. And the performance status of patients, if they have a better performance status, that benefit was even more striking. So that's interesting to see. These are the patients who we can introduce palliative care earlier, and they have more to benefit from. So let's take a step back and think about the mechanistic drivers of why early palliative care works. And to me, there are 3 main buckets: timely symptom management, longitudinal psychological support, and enhanced communication and decision-making. Starting with symptom management, well, if we could work with patients early on, because we all know they start with a lot of symptoms like pain or dyspnea and weight loss and tiredness. If we can improve their symptom control early on through proper education and treatment, we can improve the quality of life and satisfaction. And along the way, because they feel more confident about managing their symptoms, may be less likely to show up in the emergency room with fewer symptom crises, less aggressive care, particularly closer to the end of life. And perhaps with concurrent palliative care delivered along with oncologic treatment, we manage the weight loss, we manage the fatigue. Now they have better function, better nutrition, and can tolerate the cancer treatments better, leading to perhaps improved survival. So psychological support, we could potentially improve the anxiety and depression over time. It takes time to, do the counseling sessions and even for the medications to work. And with that, we can improve the quality of life. We also know that good spiritual care in multiple studies can improve not only quality of life, but lead to less aggressive care at the end of life through proper messaging. And then with better communication. It takes time, once again, to kind of help patients become more aware of what's happening, to develop that trust in relationship that not only helps with satisfaction, but help define the goals of care that are relevant to our patients, that may steer some patients off the more aggressive path of care, and by providing the actual plan of what they wanted to do, such as having a good, strong home care program in place that can also reduce the aggressiveness of care at the end of life. And perhaps it is the improvement in symptom and quality of life and decrease in aggressiveness of care, like avoiding the ICU visit, and along with that many complications that we could also contribute to survival benefit. So the take-home message is, it is complex. This is not a one single pathway that contributes to these complex outcomes, and it is through this multidimensional support that we believe why we can see the outcomes we see in the studies. So to me, the best form of palliative care is a preventative kind of care, that we can prevent suffering. And when we talk about prevention, what does that mean? Well, first we need to understand what's happening about the natural history of the illness. We need to have the foresight that the patient sitting in front of us is in that category and something will happen if we don't do something. We need to have effective evidence-based interventions and be able to introduce that intervention in a timely fashion, and hopefully we can improve the outcomes. So take the example then for a patient with stage 4 lung cancer. Well studied, we see that the symptom, is happening now in the patient. Let's say dyspnea can certainly get worse over time. And we know that there are effective non-pharmacologic as well as some pharmacologic therapies we could consider. And we can educate the patient. We can monitor them, we can support the caregivers over time. And that may very well not only improve the quality of life throughout early on, but also avoid those emergency room visits. I hope that all makes sense, and we see the evidence. And I think, again, you all probably would agree already. The challenge, though, is the real life does not always is running the same path as what we understand. So this is a systematic review looking at 12 million patients in different settings. It is a mix of different countries as well as including hospice patients. But the take-home message is that the median duration from palliative care referral to death is only 19 days. And so this is far, far away from what we hope to see, which 6 months is 180 days. So, we only have a few weeks to work with the patient. As a result, we are still very much in the crisis management mode, and recognizing that the studies were picked after the TAML studies being published. So, we had lots of conversations earlier today, and one of them is this, why is this happening? And we all know that this is a self-fulfilling prophecy, that there's a lot of stigma still attached with palliative care. This contributes partly to the delayed referrals, and if patients don't get to see palliative care early enough, they die shortly after. Well, that confirms their idea that palliative care is for the end of life. And this becomes a downward spiral, perhaps, to a certain extent. Well, it may not have to be this way. We could potentially have a more positive cycle of referrals. And if we could, for example, improve the referrals timing, we could have a lot more time to spend with patients, and that could introduce greater benefits. The patients see it, the doctors see it, and leading to earlier referrals. So how do we change a downward spiral to a more upward spiral? Well, I think there are a few important facilitators, and here are 5 that I thought are particularly relevant. And so one is the use of a term, supportive care, as one strategy, of signaling to oncologists that we are here to save patients, not just at the end of life, but earlier in the disease trajectory. And when we did a survey of the oncologists, they feel that they're much more comfortable using the term supportive care to introduce this service to patients. And we found that they rate of referral increased significantly after we changed our program name to supportive care. But we actually didn't completely replace palliative care. We call it supportive and palliative care, and that worked just fine for patients. Now, since that time in the US, about half of the programs now in the cancer centers are using the term supportive and/or palliative care, and as a way, and I know in Europe there's more and more centers along this line as well. I think providing excellent patient care and building that relationship with oncologists for them to see that we are doing great work and to support them, that they can now have less fatigue and more function, can certainly improve the confidence. And one patient at a time, we are building this positive cycle. Educating the next generation of clinicians, particularly oncology team members, is critical as well. And we're talking about the fellows when they are still have a mind that's moldable, when they are able to take in the information and recognize, wow, palliative care is complex, that not everyone can just do it, and we do need to get patients referred to these people who can really help our patients. And there's, again, evidence that younger oncologists are much more receptive to referring patients earlier. And of course, bringing in their high quality studies and can really improve patients' oncologists' confidence. And after all, we are a very evidence-based kind of driven discipline, and that could catalyze the process. And along with that, leadership support. Leadership support can help a lot, but at the same time, I think, at our institution, I would say the grassroots level of oncologists, just seeing the team and the function really contributed a lot. But having a top-down approach of leadership providing the resources, setting the tone, definitely helps, and having the healthcare system with reimbursement and support for palliative care can also have an impact as well. For example, in the US, some insurance companies are very advocating for more palliative care because they recognize the value that we bring. So here's some evidence. This is still unpublished because we just completed this study, but we examined the outcome of the time from referral to death for our patients from year to year at our outpatient clinic. So in fact, we have data even before that time, but here is one focusing in the last 7 years. And what we found is at that time, the median time from referral to death for our patients was 9 months, which is pretty good, already above the average. And but now moving further along, 2021 and even beyond, you can see the survival curves are higher and higher, supporting the idea that patients are being referred, engaging us earlier and earlier in the disease trajectory. So I think, at Santer, we are happy to see this positive cycle, and I think this can be done, with the right, environment and facilitators. So let's take a step back then about the evolution of palliative care from the days of Cicely Saunders. At that time, hospice care was the term, and in 1970s, Dr. Belfomant from Canada had the palliative care unit and coined this term. And since that time, it also signals a change from the community setting in hospice to more inpatient, setting. In the 1990s, one of the first outpatient palliative clinics was started by Dr. Buera, my mentor, in Edmonton. That time, this continued to grow a bit until the 2010 when you see the landmark paper with Dr. Tammo. And then 2020, we know what happened. There's the virus. And this also changed palliative care in some way. In that way, in the sense that it transformed our practice into a more telehealth approach. So we'll discuss that a little bit as we go as well. But with this evolution, it means that patients are seeing palliative care earlier and earlier, from only days of survival to weeks to months. And now we're talking about years in some centers. And the names are also evolving. Hospice, palliative, and we use the term supportive care as well. I see this as all a very natural evolution for how our field is going, reaching out to more and more people and expanding the scope and the type of services that we provide. So the question really is no longer whether we need palliative care for patients, but how do we optimize it? So we ask the questions of when, what is the right team, how much palliative care, and where is the right place as some of the evolving concepts in our field. And to answer this, we have this simple mnemonic called TIPS, which is T for timely palliative care, which we'll explain, I for interdisciplinary, P is for personalizing it based on the patient's preferences and needs for the dose of palliative care, and also S is for setting. So we'll discuss each of these 4 areas for this part of the presentation. So let's talk about timely palliative care. And some people ask, how is it different from the idea of early palliative care? And in a way, let's talk about how we get patients referred nowadays. In vast majority of programs, it is still very much what we call selective referral. That means, some patients get referred by the oncologist and some don't. So here is a cartoon. In orange are all the patients who have quite a bit of distress, and most palliative care team would say, yeah, this patient I really need to see. In green are the patients who are doing pretty good in an oncology practice. And there are lots of patients who are doing pretty good, They have good function, they have low symptom burden, or the oncologists are doing a good job already. So that is excellent. And then in the boxes showing the patients who actually need to be referred or who were actually referred. And you can see not all the patients in distress were actually referred in this cartoon, but some oncologists have a lower threshold and they refer some patients. So what this leads to is uneven level of palliative care access. So the next idea is early palliative care referral. And if we are very evidence-based, we would, really follow the, trials. And the trials are actually quite inclusive. Anyone within the first, 2 months or 3 months of diagnosis with particular cancer types, they, if you follow them, they don't have a particular symptom burden. You can just refer them to palliative care. And we see the benefits, in quality of life. So that makes sense, but this what we call universal referral is also going to overwhelm the limited bandwidth in the palliative care team, and so we don't want all palliative care clinicians to burn out, and so it is really not done typically, even though the evidence supports it. So the next framework then is what we call timely palliative care, which is systematic screening of patients, recognizing those who are in needs, and then referring the right patient at the right time. And there are patients who may not need palliative care now in green, but we continue to screen them. We'll identify who needs it later, and refer them to palliative care. And the benefit of this is that we are more aligning the resources for the right patients. And in the oncology setting, they've been doing this all along. They do mutation testing, and identify the targeted population would benefit from this. And so the concepts are very easy to understand. And is there evidence to support this approach? Well, Dr. Zimmerman conducted this randomized trial palliative care, and there's a cluster randomized trial that was very nice in Canada, and we collaborated with her and look at a subgroup analysis of patients who have high symptom burden, the ones in orange, versus those who have a lower symptom burden at baseline. And what you can see in the intervention arm is that those who have a high symptom burden, they were the ones who were more likely to benefit from palliative care, whereas if they're low symptom burden, not so much, not as much at least. And then in the control group, regardless of whether high or low symptom burden, they deteriorate in the quality of life. So this kind of is one way to support the idea that, this more selective approach could potentially help and also, triage patients properly. How do we do this timely palliative care? It makes sense. We need 4 major elements. We need routine screening of patients, which we know from the literature makes a lot of sense. And, this group's done a lot of pioneering work in symptom assessment as well, but it goes beyond symptom. And then also to think about having defined referral criteria that is rich between the oncology team and the palliative care team, then you got to have some algorithm to match up, when patients meet the referral criteria and trigger some form of referral. And ultimately, maybe this is the most challenging part, is to have a large enough outpatient palliative care program to actually take up the increase in referral. And this is not just increase in volume, this is increase in the timing as well. And there are some papers, I just don't have the time to show you all, but you can see the literature associated with that. And certainly these metrics can be met through this fairly straightforward timely referral pathway. And this leads to better outcomes and better access. And so one question we often get asked is, then who should be referred? So a while back, we, conducted a Delphi study asking a panel of international experts, who are the patients who, among for the oncologists and palliative care specialists, who should be referred to, specialist palliative care in the outpatient setting. And, as long as they have advanced cancer. And so the answers, and these are reaching fairly high level of consensus, which was defined as at least 70%, but some almost 100% is, if they have severe symptom distress, physical, emotional, existential, please refer them. And by the way, any one symptom or one issue is enough to trigger this referral. So in a way, these are almost like referral reasons of last defense. If you see them, please refer. Right? And the next category would be if patients need additional assistance, complex decision making, or patient asking for it, which we hope can happen more and more. And then if they have neurological complications, such as delirium, brain metastases, or cord compression, well, these patients, they even if they don't have a lot of symptom concerns now, well, they would be soon enough, and certainly have a limitation on their prognosis as well. So would be good considerations for referral. And then we have 2 time-based criteria, meaning if they are within 3 months of diagnosis, but with about median survival of a year or less, or progress through 2 lines of systemic therapy. So these are more time-based criteria, but above 9 out of the 11 are needs-based criteria. So, highlights the panel's idea that we should recognize who needs to refer based on more than needs. And the reality is this was just the first step to identify who may benefit, because ultimately each institution, depending on the resources, may need to set a different threshold, but at least this is a set to begin the conversation. So now moving on to, very quickly, the second term for the I is interdisciplinary, and this is what kind of form of palliative care true to the spirit of Cicely Saunders. We believe this work mechanistically. I guess the question is, where's the literature on it? And this is a study of like a lot of the randomized trials, and that's been done comparing palliative care to routine oncologic care, focusing mostly on quality of life as a primary outcome. And in green are the interdisciplinary teams. In red are the physician, only palliative care. In orange are the advanced nurse practitioner-led study interventions. In blue are the clinic nurse-led interventions. And in purple are the primary care, non-specialist palliative care-led interventions. So here are the outcomes, and green means palliative care is better than control, and red means control is better than palliative care, and D is no difference, and dash is not examined. So, just a bird's eye view right now, you can see that a lot of these studies where the positive outcomes are lies if the green group supporting the interdisciplinary nature can have more an impact on the many outcomes. The individual ones, of course, they are in different settings, different countries sometimes. It's very hard to compare head to head, but the idea so far is that, the impact is more attenuated, and even less so for the primary palliative care studies. So if you believe the interdisciplinary team works, then I guess the next question is, what dose of palliative care. For example, how often should we see patients? And so this is a very late new study of the Tamil group. They randomized patients with metastatic lung cancer to what they call step palliative care versus routine scheduled outpatient palliative care. So typically in the outpatient setting, we see patients every 4 to sometimes 6 weeks, and continue to see them until they, decide to not follow up. And, the alternative approach someone advocate because of the limited resource would be, well, we see them for the first time, and then after that, only as needed. If the disease progresses or they get admitted, we can then, see them at that time. Or, if patients were found to have a quality of life decrease of 10 points or more in the every 6-week screening, then they would be shifted to more scheduled every 4-week palliative care. So would this kind of titrated palliative care help patients' quality of life? And the question that was asked was whether this was non-inferior to what we believe is the gold standard of scheduled palliative care visits. And so the non-inferiority study did show that there is the two are the step palliative care was non-inferior to early palliative care group, and so that confirmed the hypothesis. And interestingly, the hospice stay was longer, in the early palliative care group, suggesting that perhaps having these kind of conversations more routinely could potentially help steer patients with their goals of care and care planning as well. So another direction we asked was, well, but that was for patients who are maybe relatively unselected, so everyone, as long as they are early in the disease trajectory can be referred. But we, in the principle of timely palliative care, want to ask the question, should we see patients, have moderate symptom burden, and limited to that, and then randomize them to a higher level of monitoring. That means in addition to the every 4-week visit, we actually add through remote monitoring weekly phone calls to see where they are at. Because what we found is these patients, they have more symptom burden. They often say, well, I still have pain, but I'm not too sure. And you ask them to call them, but they don't always know, all the details of the logistics. So can we be more preventative in contacting them earlier on? And so this is actually increasing the intensity of support for patients as compared to standard palliative care. And we just presented this. It is a small study, and so I would consider a pilot at this time. We did see that the primary outcome of symptom burden did improve a bit more, and was statistically significant for this within group comparison. But whereas the usual standard palliative care group did not improve significantly at the primary outcome time point. Also interesting is that the quality of life improved even more so in the group with remote monitoring added on top of standard palliative care, and by 12 weeks, you can see the difference. So this provided some preliminary data for us to further investigate, but I think it is consistent with our hypothesis. And the next question, the last part would be the S. So where should we be providing care for these patients? Recognizing that outpatient is the place where the longitudinal care is provided, but some patients will end up in the hospital. They need it, and others would need home-based or community-based care. And ultimately, the idea is, if we have a adequately funded system, we can provide palliative care to the right patient at the right place and the right time. And telehealth has catapulted this significantly. So here is, one recent study looking at the from this group here, looking at out of hours palliative care phone lines, suggesting that more evidence is needed, but generally there's some, emerging benefits. And the idea is if we can provide palliative care early enough for patients and in a comprehensive way meet where patient is at, whether it's through the outpatient, in the acute palliative care unit or through the home program, we can not only support the decision making, but also have an impact on providing the kind of alternative to dying in the hospital and the ICU. So ultimately, telehealth has transformed our care, and in our survey, we, of 200 patients who have been through not only inpatient, obviously, but also telehealth services, we asked them, what do you prefer? And these patients strongly support, they like telehealth, virtual visits, and only 9% say, yeah, I'm in person is what I prefer. And, patients like it for the great degree of convenience, and also they don't feel the thoroughness is jeopardized for this. And of course, there's a latest study from Gear et al. Showing that virtual visits are non-inferior to in-person visits as well. And I think this supports that this type of care could potentially facilitate us to reach patients where they are at as well. So the summary of this presentation is that the question is no longer whether early palliative care is beneficial, but how can we personalize it? And we talk about timely palliative care, interdisciplinary, personalizing the dose based on who we are seeing and what the needs are, and also in the right setting for the patient. And at the end, when we talk about integration, we really need to think about that it's not just having good clinical program is enough. We absolutely need the research to bring the evidence to support the practice and train the next generation. And we need the education to provide the next generation of researchers and clinicians, and perhaps even administrators who can in turn bring the advocacy, the resources to support each of them. So I think regardless of which role you have right now, you have an important role to continue to build palliative care forward one step at a time. And Lancet published this commission on integration of oncology and palliative care, and essentially highlighting some of the many principles we talked about earlier. And you have a visionary leader, Professor Higginson, who clearly advocates for this important message of more access, and also more research. That is what our field needs. And so, I talked about two women who I admire a lot. Another one I just want to end my presentation is my mother. So coming back to the UK is very special for me, being in this prestigious institution. And I, also personally is very meaningful because I was born not too far away from London. And, what I remember in childhood is walking, to school with my mother in the fog, and you can see the fog can be pretty thick sometimes. You can't see too far, right? And but I know holding my mother's hand, that she has a sense of direction and, she will guide me to where I need to be. And, if I think about reflecting this, this is what palliative care does, is to help patients navigate this uncertainty and help them achieve their goals. And so thank you very much for your attention. I also like to thank my collaborators, my mentor, Dr. Buera, and the team, as well as, the funding agencies for many of the support for some of the work presented here. Thank you for the opportunity.
Thank you so much, David. I'm delighted to say that we now have some time to take questions from the audience for David on his talk this afternoon. So who would like to open with a question? Great. Yes, we have one over here. Thank you.
So thank you very much for your presentation, and the clarity of your thoughts and your slides were marvellous, so thank you very much. My question is about how we can adapt your thinking and your research to other conditions such as heart failure. So on the train on the way home, I'm bit late on a grant application, and I'm going to change early to timely. I'm already going to do that. But any other tips and thinking that we could extrapolate to outside of oncology? Well, thank you for your presentation.
Thank you for this.
Just like to introduce yourself.
Sorry. So my name's Amy Gaddu. I'm a academic in palliative care in Lancaster and Blackpool. Thank you.
Thank you for this wonderful question. I think, you have a tremendous group here who've done so much, groundbreaking work in, not only cancer, but non-cancer, conditions. I kind of see cancer as just one model. I think the principles that we learn, there are many failures that we have tried and some breakthroughs we have been able to make. Maybe examples. I mean, the principles would not change, such as the interdisciplinary nature, such as the timeliness nature, that we can prevent the suffering rather than waiting till it happens, that we need to titrate the dose. All these principles are, there. But of course, patients with dementia, have a different trajectory and set of unique needs that we need to be mindful of. The decisions are different. But just as an example, we were able to publish that list of referral criteria for cancer patients. But we also collaborated with our colleague in Australia, Jennifer Phillip, and our groups working together to work on referral criteria for patients with dementia, with heart failure, with COPD, with chronic kidney disease. So, just not only clinically, we can think about the opportunities to, kind of build on this, but also research, maybe some of the things that's been done. Others are a little bit behind, maybe a little bit behind a lot behind in some other areas. But I think those are opportunities for us to kind of say, well, this works. Why don't we apply it and see how it works? And we kind of identify some unique, criteria that would say for heart failure patients, advanced, cardiac support therapies, for example, kind of when do you need to involve specialist palliative care teams? So of course, that's just one small step, but it's an example of, I think, how we can apply some of the principles, not only in practice, but research as well. Thank you.
Thank you. Another question from the floor. Yes, thank you. Would you like to introduce yourself?
Hi, my name's Jo Bailey. I'm a postdoc researcher here at Cicely Saunders. I met you this afternoon and was delighted with your presentation just now. Thank you. It's really lovely to see the trajectory of palliative care research over the years presented so clearly. I'm interested in the slide where you talked about the triggers to referral and severe symptoms and other aspects from the triggers to referral. And I'm thinking about the composition of the palliative care team and whether the triggers to referral need to be a little bit more discriminatory for different members of the team. Thinking about advanced care planning that we bring in early for timely decisions for future care. Do we need to look at function-orientated palliative care as a trigger for referrals when people are experiencing changes in function? And is that something that we need to include in lists of triggers to referral? Thank you.
Yeah, thank you very much. I appreciate that comment. I think all studies have limitations. That study, there was a limitation that we focus on physicians, and so, they always a perspective. I think you do recognize that there are other angles, but I would say those criteria is just a starting point, and that it is so important to tailor it to each, unique institution based on the resources you have as well, based on the team makeup, and kind of have that consensus with the oncology team. And, the concepts hopefully make sense, then applying it. There's a whole field of implementation science that we, can think about, but ultimately, rolling them out. I think we also ask patients. We did a separate study asking patients, when do you think you need to be referred, and those patients have seen palliative care at least once, so they know what it is all about. And so interestingly, those patients, they, number one, the median survival was about 9 or 10 months, and they felt that generally it was about right, although some still felt that it was too late. And the number one reason that patient felt that they should be referred is about the symptom burden, particularly physical. So they do recognize, I think, we're not getting away from that, is that we are there to support them, in a large part about the physical. But there are other aspects, and I think, that's where we have, kind of more studies are needed, especially in the non-cancer, fields of multi-comorbidity, they're so complex, and I think, but these are opportunities for us to do more research. Thank you.
Thank you, David. Time for another question from the floor. Yes, thank you.
Hi, I'm Matthew Maddox. I'm a professor here at the Cicely Saunders Institute. I'm interested, maybe you might comment on how your department, it's quite local, but how your department works with the hospice sector in the US and how that fits in this development picture.
Yeah, so thank you for your question, Matt. In the US, hospice is more home hospice. So they provide essentially for anyone who's like 6 months or less of expected survival, they would qualify for hospice. But in reality, hospice is not engaged, into the concept of that vicious cycle until often like 1 or 2 weeks before patients die. So, patients, but, what we have is this early palliative care where we can support patients throughout the illness trajectory. And if and when they find that it is very hard to, get back and forth to the hospital, or nowadays, even with telehealth, it reduces that, burden on them, then they could get hospice benefits in which they get the equipment delivered, the people visiting. Essentially, I see it as a more comprehensive form of home care. So it is quite different from the UK model as well as others, and I think this highlights the importance of recognizing every healthcare system is different, and that the solutions got to be local as well. With adaptive teams, even though the principles, I would still argue, are very much similar. Yeah. Thank you.
Thank you, David. Do we have another question? Yes.
Thank you. Hello, I'm Matthew Reid. I'm Chief Executive of Marie Curie in the UK. Thank you for your excellent presentation. Just to pick up on the previous point you were making around different healthcare systems, we're potentially going for a bit of a relook at how healthcare works across England over these next few years. Did you have any sort of top tips on sort of 3 things you think from your own experience we could be doing better in the UK to more mainstream palliative end-of-life care for more people?
Well, that sounds like a great question for Dr. Higginson.
Yeah, but you're up there.
Yes. Well, I think talking of tips, and I guess people already use that term, but, I would say that, I have to say the experts are here, rely on your local experts who have a deep understanding of what is needed. I think that may be my best answer. Of course, we all work very hard every day to advocate for palliative care, in our own ways, whether we're seeing the next patient and knowing that patient can do better. And, I think we're promoting the field, educating, the next, person who might want to learn more about palliative care or doing the research and the policy changes. So I think this is hard work. But if you look back, how times have changed, I think it is evolving, and so I'm very optimistic about the future, and I hope, we can all continue to build on it. And, this afternoon met with many, young people, and I think it's very exciting. I think your institute here is training, a tremendous group of people who are not going to change care here in the UK, but around the world. So it is fantastic to see this kind of incubator and the tremendous work that you are doing already. Of course, there's a lot more work ahead.
Thank you. I think we have time for one more question. Yes, please.
Hi, I'm Joanna Davis. I'm a research fellow here at the Cicely Saunders Institute. Thank you for a fantastic presentation. My question is about equity. I wondered in those lovely survival graphs that you showed us, whether you've been able to look at kind of subgroups in terms of whether some groups are more likely to benefit from the timely palliative care interventions, groups other than just looking at the split between high and low symptom burden. So I wondered partly whether you'd looked at that. And then also a kind of more general question about how we can ensure that all groups in society benefit equally from improvements in palliative care.
Yeah, I thank you for your question. It's very topical, and certainly I think one of the key principles of palliative care is to recognize the vulnerables and to support them. And I think we are getting to be very mindful, and whether we are clinicians practicing every day, seeing patients, or researchers looking at those important variables, or even journals. In a journal editing, and we are thinking of are we kind of some subgroups of investigators? We are more less likely to accept their papers, and so I think every aspect of that, some of this implicit that we got to be very careful about, but the reality is we got to have the data. So if we do more introspection and actually publish them, then it gets some attention, and identify not only the gaps of knowledge, but the gaps of care that we can promote. So I think, truthfully, there's still a lot of gaps, and we need to work hard to fulfill them. So thank you.
Thank you, David. It's now my pleasure to invite the closing remarks from Kate Kirk, who's the Chair of the Board of Trustees of Cicely Saunders International. Thank you, Kate.
Thank you. I hope that clapping is for David, not for me. Yes, I'm Chair of Trustees of Cicely Saunders International. We are closely entangled, if you like, with the Institute here. We are a charity, and our aim, in a nutshell, is to make high-quality palliative care available to everybody who needs it, which is, just a small little goal. We'll keep it small. David, your lecture was brilliant, and it was fascinating, and I like the way that you integrated sort of earlier knowledge and studies, and it's sort of building up this huge body of evidence about something that probably, if you thought about it, you think it was a no-brainer. I mean, it sort of seems obvious, but you need all that kind of evidence and that research to be able to demonstrate it. And it's very important we're seeing how cancer care in particular is evolving for patients and families and health systems as we move forward. But I just briefly wanted to say a couple of things about Cicely Saunders International, the charity, because there may be some of you who don't know much about us. We've been established for over 20 years. We've raised over £20 million. We've roughly doubled that in terms of leveraged funding and research grants and other income streams for specific projects. One of our early goals was realised when we partnered with King's and raised 10 million to develop this building and this institute to create a hub for the kind of multidisciplinary research that's so important. And recently we've been very delighted to congratulate not only Professor Harding, but also Professor Evans on moving into new and even more important roles than the ones they currently occupied. So we're delighted, and we're very glad that Cicely Saunders International had a small role in supporting them along their journeys. And we continue to seek ways of supporting not only leading-edge research into all aspects of palliative care, but also developing the doctors, the nurses, the physios, the social workers, the researchers, the scientists, and everybody else who contributes to growing and advancing palliative care, as David outlined so clearly in referring to the needs for interdisciplinary operating, if you like. And looking ahead, we're really excited that we're being involved in the King's Better Health and Care Futures initiative, which it aligns very well with our mission and our action plan for palliative care, which you can probably pick up outside if you haven't already downloaded it. Not least because this is something that really puts patients and families, however those families are constituted, at the centre of care. And we saw from those diagrams that everything is connected. There are no silos. You have to kind of join everything to together to actually really make a difference. So we're feeling that this idea of expanding a care force, if you like, and improving things across the healthcare system, even if it means frugal innovations, we might find there are ways where you don't have to spend lots more money in order to make a big difference. And community engagement and empowerment, all of those kind of speak to our purpose as a charity. And Cicely, I don't think this is a conflict of interest. She was my aunt, so, you know, nepotism maybe. But anyway, she famously said, as you can see on that stand over there, you matter because you are you. And that is her talking to patients. And I'm going to very cheekily add to that from our perspective, perhaps she really ought now to be saying, we all matter because we are us. And we're the ones together that are building this better delivery of palliative care. So that's all I'm going to say. I'm going to say thank you again, David, for your fascinating talk. I'm very much hoping I might be able to get hold of the slides so I can nick some of them. And please, would you, all of those who are here in the room are very warmly invited to join us out in the atrium for a drink, for a chat. There are plenty of Institute staff around, some trustees from Cicely Saunders International and others, so hopefully we can have some interesting conversations over a glass of wine or a cup of tea or a piece of cake. But thank you very much for coming and enjoy the rest of your evening. Thank you.